Today we'll be talking about disclosing a diagnosis. And last year, I kind of introduced some idea of whether we should even be using the word dementia or not. Frustratingly, since that has happened, our whole O2 or EPIC diagnosis has basically changed. So I took out that information, but it's an ongoing discussion in the field of exactly how we should define neurocognitive disorders, especially when discussing with patients. As far as, so these will be rotating and you can ask for it down at the bottom. I don't have any disclosures with this talk at all. So we'll just briefly touch on the importance of disclosing a diagnosis, right? In those will include just sort of those tips of how not to do it, but then also how to disclose a diagnosis. And overall, improving our process is the goal of this talk. But not only that, it's what comes after a diagnosis, because that's an issue that we deal with as a healthcare system in general. And what are we doing at KU and trying to help out with across the state and the region? So I think the first point is it really behooves us to improve our diagnoses, right? I think this is something that is a moving target. That's partly why we give 17 pocket talks throughout the year. That's why we do 7.5-hour training sessions on dementia update courses. That's why I give 2 Spark Lewy body conferences. I think disseminating that knowledge is necessary, especially when we have 50,000 patients across the state of Kansas with dementia and only so many providers that can see them as far as specialists, right? So I think when we talk about improving diagnosis, I think part of it is kind of knowing where to find that information, right? So obviously, these talks, we record them, we put them on YouTube, trying to help out with recognition. There are resources out there though to help. And this is, if you give the wrong diagnosis, you can do all the right things with disclosing, but if we're not right, then that doesn't necessarily help the long-term process. So that's an important aspect for sure. As far as the importance of it, so I mean, I think in one instance, right, it allows us to stop and pause, right? So if you've got someone with early cognitive impairment, like I just saw a patient yesterday that has early mild cognitive impairment, is it probably early Alzheimer's? Yes, but they've also got severe drops in oxygen throughout the night, and they could have pretty severe sleep apnea that's never been evaluated. Right, that should be something that it should really pause us to stop and look at what are those reversible and contributing conditions, and address those, because that could have an impact on how fast things progress, even if we are dealing with early Alzheimer's. For family, right, a lot of the history really comes from family. It doesn't come from the patient in these disorders, but there's been usually things being noticed over weeks, months, and usually even years of changes that are going on within this individual, and receiving a diagnosis helps validate those concerns, but then also helps explain the nature of the problems. And then it starts to open doors for access to services. We see lots of young onset, younger than age 65 patients. So if they're unable to work because of these symptoms and they don't ever receive a diagnosis, they don't ever get access to the proper services they need. So there's lots of reasons of why it's important to establish an early and correct diagnosis. Treatment-wise, right? So there are medicines that can help with memory, especially at earlier stages. They work much better at earlier stages than they do at later stages. But then also starting that process of oversight of other medical conditions. We have many patients that their hemoglobin A1C went from 7 to 13 because they were trying to manage their own insulin, right? And when they had early dementia, that's not really possible. And if that goes unrecognized, then so do many of their other health issues. Hypertension puts them at risk of strokes and other bad outcomes, right? And if they're not taking their medicines appropriately, that's going to impact their brain long-term as well. And then, that idea of removing the medications that could be contributing, which we've talked about that numerous times in previous talks. So I would direct you to those on the YouTube channel. Increasing opportunities for research participation. So, most of our studies are looking for, we think we can make the most impact at the earliest of stages, right? Once billions of neurons have been lost when we're in the dementia stage, there's less hope for research interventions. We still have research studies for those stages, but the earlier we can get folks plugged in with research, the better for the moving that needle forwards. And then receiving early diagnosis helps plan, right? It helps reduce unnecessary risks and basically take those proactive approaches for transitions throughout the next few stages of life. When you poll Americans, at least, 90% would suggest that they would want to know. There's a certain percentage that would not want to know, and they shouldn't be coming to see a specialist or even get cognitive testing if they really don't want to know, right? There is some concern there, right? With, do they have insight? Do they have the ability to properly, from a capacity standpoint, do they have, so a lot of times it's actually family bringing them in, right? We have this sort of ongoing battle of an appointment gets made in the memory clinic and then the patient calls up and cancels, but it was family that instigated the initial visit, and it probably should not have been canceled based on just the patient, right? That's kind of an ongoing discussion for most patients, especially if there is backing from their main doctors and saying, hey, we really want you to go see the memory folks just to see what's going on. That can be alleviated, but it's not an easy discussion for some patients, but the vast majority still want to know. And for patients and caregivers, that can give relief for explaining, some sort of closure of what's going on, right? But according to the Alzheimer's Association, less than half of patients are told they have dementia by their provider. So we also see a lot of patients that are on memory medicines but have no idea why they're on them, and even families too. This is not unique to the US, so it's even much worse in other countries, especially with some paternalism that happens within the healthcare system. PCPs are still the front line of seeing patients with these disorders. We've talked about this in other talks. There are not enough dementia specialists, and that's a problem everywhere, not even just in the US. And increasing age and just overall numbers exacerbates this problem. 39% of PCPs say they're never or only sometimes comfortable making a diagnosis of Alzheimer's disease, and that number is even lower for Lewy body disease or other types of dementia. One issue is time, right? You need time to do these things to get a thorough evaluation, but also for disclosing a diagnosis and having that discussion. Fortunately, we do have chronic care models that are starting to alleviate some of those issues, but obviously time is still of the necessity, but billing by time is helpful. Family and caregiver issues, right? This can create a lot of extra burden on staff. So with nursing calls, frequent calls, missing appointments. So because of the memory issues, right? And then the whole logistics of getting to the office visit, those can all be issues with these diseases. So some tips on how not to disclose. I think the main one that I hear about, especially hearing it from other families, of kind of what they value out of our clinic is really just not having enough time, right? I mean, if you really think about it, right, this is a life-altering diagnosis, and spending 5 to 10 minutes, saying we think you have Alzheimer's disease, and moving on is not really adequate, right? I think another issue I hear about is not involving the family, right? So if you look at, even folks with mild dementia, almost 3/4 of them cannot explain their diagnosis shortly after disclosure. So obviously memory being part of that, but overall understanding being the other part. Leading with the diagnosis. So, I think that's just delivering bad news 101. So establishing that rapport and preparing the patient. I usually like to kind of let them and even families sort of tell me what they understand, what's been discussed in the past, especially since I'm usually kind of a second or third opinion a lot of times. I'm trying to see what their understanding of everything is first. Being definitive without evidence is an issue, right? So, these are complex neurologic puzzles, right? When we're dealing with, neurocognitive disorders, So if there's any uncertainty, then that would be an indication to seek more tests, doing more detailed neuropsychologic testing. If there's concern of maybe the bedside screening cognitive test is not adequate enough, maybe it's getting a more advanced scan like an FTG PET scan. Biomarkers can be done now, right? Or sending a referral for a second opinion. So, I don't think I can have this conversation in less than 30 minutes in most cases. And part of that is there's a lot of time, there's gonna be a lot of questions, right? And so I think that so time is necessary to set aside for these conversations. And then I already kind of laid this out, it's from the last slide, but having someone there present with them, and if anything, right, them knowing what's going on too, and then preparing them for, we would recommend medication oversight, right? Because of this reason, making sure that these other chronic health problems are being watched closely. And then I sort of said this previously, but sort of exploring the patient's perspective of the problems. I will tell you the vast majority of times patients will not have enough insight to really understand exactly how severe something might be, if it's going on. But sometimes you're surprised. Some patients are very, very insightful into what's going on. You do want to get a sense of, is there some denial or wishful thinking here, right? Are there unrealistic expectations? Because you're going to have to address those and deal with those if that's what's if that's kind of underneath the surface. When patients have lack of insight, that can be very tricky to deal with, and ultimately that's where you're involving the family even more, right? Just kind of letting them know of this is actually part of the brain problem, this lack of insight. And then, reassurance that you've kind of taken everything into account, right? You're not just making this diagnosis on a whim. So I find personally that neuroimaging can be helpful. I think whenever I pull up someone's scan, that just changes everything, right? So if they can like literally see their scan, why am I having memory issues? Well, there's shrinkage of these memory structures, right? And so I include, if you ever receive notes from me, I include the images in their notes, and I go over them with them in the visit. And there's a clear explanation of what's going on. So like, for example, with an FDG PET scan, if I've got someone with primary language or primary word finding difficulties, and I can pull up a PET scan that literally overlaps with where I would expect problems of naming and word finding difficulties to arise from, this, a picture is worth 1,000 words in that scenario, right? It's very clear what's going on, and it helps kind of with that understanding. I do try to set the stage, right? I try to acknowledge the changes more of, I try to mirror their language. So a lot of patients will not, they'll sort of become defensive if you call something, that you've got memory impairment or problems. If we focus on using language they're using, that can sometimes help at least break down that barrier. I always point out that no single test makes a diagnosis, right? And that's why we do this. We do an MRI, we look for certain reversible changes, we look for other contributing factors. That's why we do the lab tests, we check for sleep apnea, we look at the medication list, right? And if we've done all that, we've met all those check boxes, and we have clear objective cognitive impairment on testing, then that is helpful. I like to go over percentile ranking for them, right? So when we do neuropsych testing, our neuropsychologist will usually give a summary of the report, but then I kind of compare them. How can I tell this is normal aging versus abnormal aging? Well, it really comes down to how this report is comparing you to others in your age group. And so creating that confidence is important, right? We're kind of building that case. And if it's sort of a neuropsychology report or a report from the memory clinic, right, you're then able to rely on that specialist report for this overall case that you're building, right, of what's going on. I sometimes use working diagnosis. I use possible, probable. Those are totally fine to be using, right? But if we're using those, then we probably should be doing further workup or asking for a second opinion, right? But I think it's still okay to label something as, hey, I think this is what I'm most concerned about going on. So they're not just hearing that for the first time once a test of, say, Alzheimer's biomarkers comes back positive, and then they're shocked about the result. So disclosing the diagnosis directly to the patient, assessing the understanding, right? I think these are all kind of, we all learned this in medical school as far as delivering bad news. So I won't belabor that. I think this is part of the issue. So what happens after a diagnosis is a major shortcoming, right? There's oftentimes this very unclear path of what happens after a diagnosis. And I think that has led us to not want to disclose a diagnosis as providers, and sometimes probably not seek a diagnosis if you're a patient, right? Part of this is lack of resources, but maybe even more so lack of where to find those resources or what is even out there. Right, there are plenty of programs as far as adult daycare programs, just even cognitive sessions, right, that include classes, and there are exercise classes specifically for patients with dementia and cognitive impairment. There are a lot more resources out there than most of us realize. It's just how to find those. But we could still do a lot better, right? There's not enough. And that as a society, we just have to grapple with and advance that. We have to have better options for patients because this is not going away. We have a lot of issues with communication. So that could be even from a specialist communicating with the primary care provider that made the referral, right? That could be lack of communication with the family themselves of what next steps they should be taking. Oftentimes it's sort of a pause and then okay, what do we do now, right? And so I really think that is something that we really need to improve on. There's usually a lack of information of what research studies are out there. And then a problem that I struggle with, even when we start to get all these things correct, we don't have great predictors of, okay, are you going to be someone that's going to progress rapidly in the next year versus a slower progression over the next 10 years? We don't have a test right now that is a crystal ball in that scenario. And so I do think it is appropriate to at least foster some hope, right? I mean, there are things you can be doing to slow down changes, right? Especially if things are diagnosed early, right? So lifestyle recommendations are huge here. We need to focus on overall health and well-being. If there are trips that they planned on taking, doing them sooner than later is recommended, right? But overall engagement of the brain through physical exercise, cognitive exercise, right? These things do matter. Getting them involved in research is important at early stages as well. I find personally that is tricky. If patients are very mildly affected, they might not want to get involved. It's usually once we've reached later stages where it's sort of a desperation call of, hey, I want to get involved in the most latest research study, when that's not the time to necessarily get involved. We certainly have research studies for later stages, but that's, there's been a lot of changes happening in the brain at that point. I think for patients with later stages, we really need to start focusing on quality of life at that point, right? And then preparing for transitions. But still, as much as we can, getting those lifestyle things in place, because we can stabilize in some scenarios. So obviously research we talked about. Planning for a follow-up, right? So obviously a diagnosis doesn't end at that visit. Maybe it's a follow-up with your social worker. Maybe it's a follow-up with your colleague, your advanced practice provider. But there needs to be some sort of, hey, I want you to go home, process this. Here's some information, write down some questions, and then so we can meet back and discuss it, right? That's important. So I think as if you're a provider that sees, especially like a geriatrics provider that sees a lot of patients with dementia, having those appropriate social support services, a social work team is necessary. Partnering with our cognitive care network team would be quite important for making sure that your clinic is dementia ready, right, and capable. A lot of their mantra of our cognitive care network is being proactive rather than reactive, right? Too much of dementia care is this moment of crisis, right? We see it all the time. Patients get admitted to the hospital for some reason, and then it's pretty clear that they're going to need to be transitioned from somewhere else. There's a lot of delirium, and that's unfortunately when a diagnosis gets made. Is like in a hospital setting sometimes, and having these things in place earlier requires an earlier diagnosis, and then that can even help the transitions into the hospital, because these episodes of delirium are going to worsen symptoms more rapidly too. As far as next steps, so, I think it isn't, we had a whole talk on why we prescribe certain medicines. We had a whole talk on trying to minimize the contributing factors, right? So anticholinergic meds, CNS depressing medications. I've had some patients just dramatically improve with removing medicines, right? And so that has to be the role of the primary care provider in ruling those contributing factors out, treating the sleep apnea if it's present, dealing with the anxiety symptoms that are occurring. Lifestyle is really big here. I think encouragement of those things is important. We have both the My Alliance group and the Cognitive Care Network team. So that's our caregiver support, but this is also partnering with many of the primary providers across the state of Kansas and in the region. Here's our LEAP program. So this is very accessible for most patients. There's ways to do modules and boot camp, or there's ways to just review the information on the website. But I think these types of things are important to offer patients and family members. And sometimes it's literally the daughter, right, or the other family member. Well, what can I be doing to protect my brain right now that I'm at slightly increased risk? These are the things, right? You can really delay the onset with these types of things. So we think of our Cognitive Care Network team, their ideal role is to incorporate at a time of diagnosis, right? At a point of diagnosis. And so the goal here, right, is to basically provide those resources early on. So we have classes for caregivers, right? We have dementia training courses. Sometimes just how a caregiver responds changes the whole situation, right? And so education on what are some good ways to respond to certain situations, certain symptoms, and how not to. Those are all the non-pharmacologic strategies that we have available to us, and those work much better than any medicines we can provide. So that's sort of our role and goals with this. But we're currently partnered with over 81 PCPs, and that's growing, and that is something that we can only take on so many patients as a specialty clinic. So we're really trying to help train other social workers and other primary care providers to help their patients, right? And we really have to expand that, and that's the ultimate goal with all of this. So this idea of shifting the point of care, right? So Michelle Needens is the head of our Cognitive Care Network team. She's the main contact point, but we have a group of individuals that are part of the team, and then a wider net of a network, right, involving local communities, especially regional and even rural areas that we can at least train and have liaison contact with. The whole goals, as I said earlier, are to really try to move that crisis model into more of an empowerment model, and providing a collaborative practice, right? So it might not be necessarily that, oh, we can see your patient tomorrow because of this issue, but we can make recommendations as sort of a team, right? So if they've seen us in the clinic and they're connected with the social work team, these recommendations can go down to the primary care providers. So there's access to specialty care without an exact appointment, because we just don't have availability to do so. Overall, these goals of improving quality of life, we see this in our impact surveys, right? So, both from the community, but also from clinic referrals, this is widely beneficial for patients and their family members, and this is backed up by our survey data. So I think it is some, there's a lot of variability in how patients engage with our team. Medicare does allow for chronic care management billing now, so a certain percentage of our visits are even billable, and that's where we're checking in once a month. So the social work team's talking at least monthly with patients and mostly their family members about changes, about things we can modify, right? And trying to get ahead of those things rather than being 6 months down the line and being in a moment of crisis. But other times it's, hey, we don't really need anything right now, but at least we know who to reach out to if questions emerge or if we need more information. So it's highly variable with each individual, but having those resources is necessary. So I'm going to go ahead and stop there. I think I'd be open to, let me just see what's in the chat here. Let's take a look. So a lot of it from our team and the codes. Yes, the code's good. Let me see if there's one question in here. I don't see any questions. Yeah, so resources were put into the chat. So information on the LEAP program is in there. And then the education programs of what we offer, both on the provider training side, but also on the caregiver training side. Those are listed in that area. Any questions? Feel free to unmute or type in the chat. There's always questions about biomarkers. I think that's an ongoing that's in flux. I mean, even as a specialty clinic, we currently only get Alzheimer's biomarkers on probably 10% or less of our patients. I do it in cases that are young onset or where I don't feel like all the puzzle pieces are matching up. But they're going to be more and more useful. So especially if patients are interested in doing the new, if they're interested in the new medications that are anti-amyloid drugs, they're going to require biomarker testing. So it's going to become more of a mainstay. I think that's going to be even more useful when we can do it as a blood biomarker, but that's still an ongoing area of research. So right now in the clinic, we still do it through spinal fluid analysis. So Chrissy asked, so where can a person get a cognitive eval done if not offered in primary care office? So, I mean, I would say, so Christy, first, I mean, it depends on the scenario. But if there's like strong family history, there's concern, there's oftentimes normal aging symptoms, which we've talked about in the first few, talks at the beginning of the year. A detailed neuropsychologic evaluation can be ordered if there's ongoing concern and family history. I think there is some confusion of what does our clinic do? Our clinic specializes in a diagnosis, and we need those pieces of the puzzle in order to make a diagnosis. And where does that get done? It gets done through neuropsych testing, which a neuropsychologist does. And then if that testing comes back, hey, you're testing normal and for your age group, right, then that's very reassuring. If there are some deficiencies seen, then maybe there are those reversible things to look into, right? Maybe we need to check sleep. Maybe we need to look at the medication list. It doesn't mean a diagnosis is necessary at that point, but if nothing else, it helps establish a good baseline to compare to if there are changes down the line. So yeah, asking for a referral for detailed cognitive testing is what I'd recommend there. All right, it is 12:44. If there's not any more in the next minute, I'll go ahead and hop off. I think, oh yes, there was a post there. So Spark, we are doing one more session for the year, October 14th. So that's a Saturday. And it is, it's a Saturday from 9:30 to 12. We basically show the Robin Williams documentary, and then we go through, I give some talks on sort of the overview of Lewy body dementia diagnosis and then treatment and understanding Lewy body disease. So that's a really good interactive session if you're available. This one's more for the community. So this is providers and families. It's not specific to providers that we do earlier in the year. So you can reach out to our team to sign up for that. It's free. So All right. Well, I will hop off. Thank you all. And maybe I'll see you at the Spark session, or at least at the next Pocket Talk.